Everything so far has been about the uncomplicated woman. The membranes break at term, the fluid is clear, the baby is head down and settled, and the whole question is when and how to help labor along. The boundary cases are not that woman with a footnote. They are a different decision made earlier, before the induction clock is even running, and the move that governs them is simple to say and easy to skip. Before you decide when to induce, you name the branch. And the branch is something you can actually see or feel on the first pass through the room. Fresh red blood, a streak of meconium in the draining fluid, a baby lying breech, a head still floating high in a first labor, a loop of cord under your fingers, the scar of an old cesarean, a woman on her 7th baby, a temperature. Each of these is a finding you screen for, and each one, if it is there, rewrites the plan before the hour matters at all. What a branch rewrites is one of two things. Either it changes which clock you are racing, it speeds up the infection curve, or it hands you a clock the term woman simply does not have, or it changes which methods are still open to you, taking the prostaglandins, or the balloon, or oxytocin before the head is down, off the table. Hold those two levers in mind, because every case that follows pulls on one or both of them. And once you see which lever a finding pulls, the management stops being a list to memorize and becomes something you can reason your way back to.
Start with meconium, because it is the cleanest kind of branch. It does not remove any option or replace the decision, it just tilts the balance. And it tilts it two ways that happen to point the same direction. Meconium in the fluid is, first, an independent predictor of infection of the membranes. It roughly doubles the odds of clinical chorioamnionitis, and in the window past 12 hours, that association is sharpest. So it steepens the very clock we met at the beginning, the infection curve that has been climbing since the moment of rupture. And second, it is a signal about the baby, one that calls for continuous monitoring in labor and a team ready to resuscitate at the birth. Now, the honest objection is that meconium at term is often nothing but a mature gut doing what mature guts do, not a baby in trouble. And that is true, which is exactly why the response is watchfulness rather than a reflex to the operating room. But the number that matters here is a number about infection, not distress, and infection is the clock induction exists to beat. So for the woman where the last lecture on the core decision left induce now as the better but genuinely optional choice, meconium moves it toward a recommendation. The reason it co-travels with chorioamnionitis is not a new mechanism. It marks a pregnancy already further up the same inflamed, longer exposed curve, the same clock further along.
Meconium tilts the decision. Blood can dissolve it. Fresh red bleeding with ruptured membranes is the case where induce versus wait can stop being the question you are answering. Because a placental abruption is not managed on a clock at all. It is managed by delivering the baby on its own indication, read off the fetal heart rate and the mother's stability, no matter how many hours the membranes have been open. This is the branch that can outrank all 4 clocks at once. And here I have to be straight about a hole in the evidence. The literature quantifies abruption after preterm rupture at a few %, but it gives no term-specific rate. And at term, it names abruption only as an uncommon immediate risk. So there is no clean number to lean on, and I am not going to borrow the preterm one and pretend it is the term figure. What you lean on instead is the rule the guidelines actually give. Most bleeding after rupture is bloody show, not abruption, so the branch is assess first. The thing that flips the plan is a concerning tracing, or a rigid, tender bleeding uterus, not a streak of blood-tinged mucus. When that concerning picture appears, the plan is expedited birth, with the oxytocin stopped, not a ripening timeline. Blood outranks the clocks because the hazard it signals, a baby losing oxygen from a placenta pulling away, kills faster than the infection curve climbs, and the fastest clock in the room is the one that sets the plan. The next branch changes neither whether you deliver nor how urgently, but how you are allowed to start. A high, unengaged, or frankly unstable presenting part is a case about cord prolapse, and the evidence places that danger with real precision. In the trials of planned early birth against waiting,
Cord prolapse is rare and no different between the two. Rupturing the membranes early did not cause it. And in a large cohort of breech births, it ran at better than 1 in 10, whether the waters broke before labor or during it. What that tells you is that prolapse is set by the presentation and by how snugly the presenting part fills the pelvis, by whether a loop of cord can slip past, and not by the timing of rupture. Which reframes the worry in front of you. The membranes are already open, so the old fear of an amniotomy washing a cord down ahead of the head is beside the point. The live fear is that a head still riding high leaves the channel open, and every contraction, every manipulation is a chance for the cord to lead. So before you start anything, you assess the level and stability of the head at the pelvic brim. You take care not to dislodge it, and if it is not well applied, you monitor continuously and keep a cesarean within easy reach. A well-applied head protects precisely because it plugs the cervix, so nothing can descend in front of it. An unfilled pelvis leaves that channel open.
And the magnitude manipulation can reach is not hypothetical. Turning a baby externally after preterm rupture with the fluid gone carries something like a 1 in 3 risk of prolapsing the cord. The presentation is the hazard, and the open membranes make its standing risk immediate.
Then comes the branch that visibly collapses the method cascade from the induction method lecture, the old cesarean scar. Recall that we anchored method selection on oxytocin, treated misoprostol as genuinely useful but conditional, and set the balloon aside in ruptured membranes because it carries an intraamniotic infection signal, better than a 3-fold rise in infection against oxytocin alone. Bring a uterine scar into that room and watch the options close. The scar takes the prostaglandins off the table outright. Misoprostol and dinoprostone are contraindicated on a scar because they soften and contract the whole muscle diffusely and cannot be switched off once given. So a scar under uncontrolled tone can give way. And the balloon was already gone for its infection risk in ruptured membranes. What is left standing is low-dose oxytocin, and even that is not free because on a scar, oxytocin induction nearly doubled the risk of uterine rupture to about 1.9% in the trial data. The fair objection is that if every method carries a scar cost or an infection cost, nothing here looks safe. The answer is why oxytocin remains the residual anchor. Its risk is dose titratable and reversible. You can stop it in seconds. So you accept a small, monitored, switch-offable risk rather than a prostaglandins uncontrolled one. And the scar changes more than the method. It changes the clock.
Because forcing this uterus is costlier. A settled trial of labor after cesarean, with no sign of compromise, is a case to let latency run a little longer toward spontaneous labor rather than reach early for oxytocin. That is not caution for its own sake. In exactly these women, the more patient protocol delivered fewer cesareans. The fifth branch works by inverting something you would ordinarily read as good news. Very high parity usually reassures. Grand multiparous women have the shortest second stages and the highest rates of spontaneous vaginal birth. So the natural objection is, why worry about any of them? The worry is not the average, it is the tail. Because their times from rupture to delivery are biphasic. Up to around the 60th percentile, they look like any other multipara and move fast. But past roughly the 70th percentile, their labors slow down and start to resemble a first-time mother's. So a woman on her 7th baby, who is still undelivered well beyond when her peers have finished, is not simply having a slow but normal labor. In a uterus that usually empties quickly, a labor that stalls is more likely stalled by a malposition or a relative obstruction than by weak contractions. And a high parity muscle tolerates obstruction poorly. That long tail is a signal to go back and reassess the cervix, the position of the head, the signs of dystocia, and to augment on purpose rather than extend the same uniform weighting you would offer anyone else. The method here carries its own constraint, from the same logic as the scar. Misoprostol is contraindicated in grand multiparity, so this overstretched, much-used uterus is augmented with careful oxytocin, never a prostaglandin.
The corpus does not give a rupture rate for this exact situation, so I will not attach a number to it. But the mechanism is enough to make the prolonged clock the thing you act on, not the thing you reassure.
The last case is not a complication inside the course, so much as the place the course ends. Below 37 weeks, a fifth clock starts ticking that the term woman never had: fetal lung maturity. And unlike the others, it does not point the same way as the infection clock. It pulls against it. This is why term is such a clean decision. At term, the cost of prematurity is gone, so the infection clock dominates, and induce now wins without much argument. Between 34 weeks and 36 and 6, the two costs are comparable, and the decision genuinely splits in two. The trial at that edge randomized about 1,800 women, and it found the trade laid bare. Delivering immediately raised newborn respiratory distress and the need for a ventilator, and brought no reduction in neonatal sepsis, while waiting roughly doubled the mother's complications: bleeding, fever, infection, and yet ended in fewer cesareans. If the sepsis rates are the same, you might ask, why not always wait and spare the lungs? Because waiting doubles the maternal infection and hemorrhage, and that sepsis equipoise holds only while surveillance and antibiotics are doing their job. So the choice trades a maternal cost against a cost to the baby's lungs, which is why at this gestation it is offered rather than dictated. Surfactant is still finishing at these weeks, and a birth that comes too soon meets lungs not yet ready to stay dry. At term, that maturation is complete, the lung cost falls away, and the infection clock is free to decide. The clean answer we have been building stops being clean the moment that fifth clock begins. So across all 6, the same discipline. Before you start the clock, name the branch: the meconium, the blood, the high head, the scar, the very high parity, the weeks still short of term. Because the branch is what tells you which of the 4 clocks you are actually racing, and which of your methods you are still allowed to use. Only once you know that does the hour on the wall mean anything at all.